So a lot of people have been interested in the paper that's talking about reinfections, and everyone's like, "Oh my God, what's happening? What's the new number, percentage of people that get long COVID? Is it 10%, 20%, 30%? I've heard it's 50%. Oh my God." Truthfully, like it's gonna depend on a person-to-person scenario at this point, and that's sort of what this paper shows. I briefly looked through it before, but we're gonna do the full read-through now. So this is a Canadian study titled Experiences of Canadians with Long-Term Symptoms Following COVID-19. And it was published or released in December 8th, or on December 8th, 2023 in Statistics Canada. Nope. Don't crawl on the desk. Just knock stuff over. Alright, so the Canadian COVID-19 Antibody Health Survey follow-up questionnaire is the result of a collaboration between the Public Health Agency of Canada and Statistics Canada to understand the long-term impacts of COVID-19 on the lives of Canadians. The study was co-authored by lead analysts from both agencies. I'll zoom in a little more. There we go. So using this data from the 2023 Canadian COVID-19 Antibody and Health Survey, so this is a health survey with a follow-up questionnaire, and that follow-up questionnaire is titled CCAHS-FQ, so not very creative. Something like Canadian COVID Antibody Health Survey follow-up question. I love acronyms sometimes. They're stupid, but I love them. So this article provides updated estimates on COVID-19 infections and reinfections among Canadian adults and describes the nature of symptoms experienced as a result of infection. Results are compared to those of the Canadian COVID-19 Antibody and Health Survey Cycle 2, CCAHS-2, which was conducted in 2022. 1 year before the CCAHS-FQ, so the current one that we're looking through, which is what's going to be reported here, but it sounds like they're going to do a cross comparison or a retrospective comparison to the 2022 survey. So I guess it's just good to know that cycle 2 is this. That makes me think there's a cycle 1, but I don't know what is going on, why they're not looking at that one too. So the article also describes the experiences of Canadians who reported long-term symptoms consistent with post-COVID-19 condition or long COVID. So we're looking at not only symptoms, where's the word symptoms? I lost that. Symptoms, we're not only looking at symptoms, but we're looking at on long COVID prevalence, including the severity of symptoms they're experienced with the healthcare system and the impact on their daily lives. Finally, this article also provides updates on the vaccination status of Canadian adults, so we're also going to get some bonus information. So the vaccine status of Canadian adults. So as of June 2023, about 2/3 of Canadian adults reported at least one confirmed or suspected COVID-19 infection. So June 2023, the estimate is that 66% of the population has had a COVID infection since the beginning of the pandemic, which would then mean that the estimate is about 1/3 or 33% of Canadians have not had a COVID infection. And multiple infections were most commonly reported among certain racialized groups like Black Canadians. So that implies that there's a possible socioeconomic factor that's influencing that. That's usually what that means. Means there's health disparities in the system, which is contributing to multiple infections because lack of access to resources, lack of healthcare access, lack of knowledge access, all these things sort of pile up in that type of scenario. So about 3.5 million Canadian adults reported experiencing long-term symptoms following a COVID infection. That's a big number, 3.5 million. Let alone So that's interesting. So maybe they don't have a child number, so they're not looking at children, just adults, I guess, in this questionnaire. So long-term symptoms following COVID infection, 2.1 million reported they were still experiencing those symptoms as of July or June 2023. So about, again, 66% of those people, or I guess almost half, it's over half, it's almost 66%, of these people, we'll drop it down, we'll say, we'll split 60%. Approximately 60% of people that got COVID got long COVID as of June 2023. And these people have not seen any improvement in symptoms over time. So among Canadians who were in school or employed and dealing with long-term symptoms, more than 1 in 5 missed days of school or work, missing 24 days on average. Okay. So that's a direct economic impact. Were the initial infections post-vaccination? So this is looking at specifically 2022 and 2023, focusing on 2023, but comparing back to 2022. So this would be post-vaccination availability. So it's not, I think that's a good point. So that's probably why. So I was mentioning earlier, probably before you popped in, it was interesting that they're looking at the 2023 Canadian COVID survey and then the 2022 Canadian COVID survey. What about the 2021? Because it's CCAHS2, which implies there's a CCAHS1, which, and I was like, why aren't they including that? And that's probably why, is because that one probably had some confounding variables from no vaccine to vaccine availability. So theoretically, these people would be vaccinated. I don't know what your question is. So about 40 of those with long-term symptoms who sought healthcare about their symptoms reported difficulties with access. So that's just a number stating healthcare lack of access. So we'll have to learn what that means within the study. And then adults with chronic conditions and senior adults were more likely to have been vaccinated in the 6 months prior to June 2023. So these are the people immunocompromised or chronic, well, no, because there's more than immunocompromised. So chronic conditions, so people with prior health issues, and older adults were more likely to get vaccinated in Canada. Or at least to stay up to date on their vaccinations. Let me know if you have a follow-up question, because I don't know what the is, or if you're just sitting there thinking. All right, cool. So that's the background. Oh, and this paper is the one that's looking at the reinfections and the burden on, oh, yeah, you're good. The burden on long COVID prevalence with the increasing number of infections that everyone's been talking about. I just decided to finally go through that study because so many people recently have been asking me, what is the number of infections impact on long COVID? I'm like, I know the paper. I have the paper title written in my notes app. I have not looked at the paper. So we're doing that right now. So starting off with the introduction, skimming through, they're just doing blah, 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 normal stuff that we always reiterate, we know. Restriction of in-person activities. That's a good phrase because people want me to look up, be like, the U.S. lockdown. We didn't lock down in the U.S., so I think that would be a great phrase for me to use in that response video later, is restriction of in-person activities. So with cases becoming more frequent, 2021 and 2022. So this is like the big thing that everyone's talking about, like being like, oh, because we have vaccinations, now we have less virulent variants, and that's clearly not the case, because JN1 is our most virulent variant that we have right now, so that is a false statement that the medical community is trying to push. I don't know why, because it's not true, but yeah. Anyways, I remember you talked about in another live the statistics don't mean everyone will have long COVID eventually. Statistics. Yeah, they don't necessarily mean that everyone will have long COVID eventually. Um, but with increased number of infections, like the likelihood's going to go up and up and up and up and up. But it does depend on a bunch of different factors like comorbidities, prior number of prior infections, number of vaccinations, most recent vaccination, time since most recent vaccination, um, like how long your exposure time was to the virus that you get infected with, how much virus you initially get infected with. Um, yeah, there's a lot of factors that play into it, but from a statistics standpoint, we're going to look at least 3 infections out in this paper. So my nose has been so itchy lately. I accidentally like cut it when I was blowing my nose, and now it's like healing weird. Anywho, so inavailability of new treatments for acute COVID infections contribute to the WHO declaring that COVID was no longer an emergency of international concern. That is not. Oh, that is a big old bold-faced lie. So the reason they declared it no longer an emergency of international concern is because they failed. Were not able to contain the virus. That is why they ended the declaration of international concern, like the public health emergency of international concern. This is a big old lie. It was not the availability of new treatments, because we still don't have treatments for COVID and long COVID. We have the antiviral Paxlovid, but not everyone can get that. And so we don't have treatments. The vaccines are coming out too slow. The virus mutation rate is becoming increasingly more frequent and faster. The turnover is faster, and we're actually seeing a reemergent. I just saw that the original Omicron has been popping up for the past few months in our travel monitoring program, the B.1.1.526, the very first Omicron, I think. Let me just double check. B.1.1.526 COVID variant. I'll just show you what I'm looking at, just because I feel like it's rude for me to not show you. It's either XBB or Delta. I just can never remember which one's which from the very beginning. Omicron. Yep, it's the original Omicron. So I saw that pop up in the travel monitoring program again. So like that's kind of concerning, because that can lead off to a brand new branch, just like we have with the BA 2.86. Anywho, so the reason why it was no longer an emergency of international concern is because the WHO declares a public health emergency of international concern to try to contain an epidemic from becoming a pandemic, but it became a pandemic and it's still a pandemic. So that's why they ended it, is because they failed to contain the epidemic in China, and then the epidemic in the local areas that it popped up in initially, and then it just became everywhere. So that's not saying that, oh, everything's fine, our treatments are good, we succeeded. That's saying we failed. And that's a very important distinction. So despite this declaration, COVID continues to cause... sorry, my partner texted me. One moment. Remind me to let the dogs out in 30 minutes. Despite this declaration, COVID-19 continues to cause significant concern for the health of the Canadian population and the wider international community. Accumulating knowledge indicates that COVID-19 is associated with long-term effects on health, including the presence of symptoms months or years after the initial infection, so let's just say long COVID. These long-term symptoms cause significant hardships that affect their health and ability to contribute to society, saying that not only is this bad for the individual, this is bad for the economy. Yes, haha. Not only is it bad for the individual, it's bad for the economy. So to provide initial insights into the burden of long-term symptoms in Canadian adults, the Canadian COVID-19 Antibody and Health Survey Cycle 2, that was the 2022 one. It's easy because you got twos and twos. Two. Was completed in the summer of 2022. The survey indicated that as of August 2022, among the approximately 11.8 million Canadian adults that had a COVID infection, about 16% experienced symptoms following their infection. So that's a 16% incidence rate of long COVID back in 2022. Sorry, that's yellow. Based off of the cause 2. And a significant proportion of those affected reported limitations in daily activities and missed time from work. And they were saying above that it was like an average of 24 days of missed work. So these and other results from the cause to have helped to improve understanding of COVID-19 infections among Canadians, which is crucial to inform public health policy, economic policy, and respond to the health challenges from COVID-19 as they arise. To examine the ongoing experiences with and impacts of COVID-19 in Canadian adults more than 3 years after the start of the pandemic, Statistics Canada, in partnership with the Public Health Agency of Canada, PHAC, conducted a follow-up study, which is this one, the cause FQ, on the respondents of cause 2 in June 2023. The study uses data from the cause FQ to describe the current COVID-19 landscape, including infection, reinfection, and acute and long-term symptoms. So they're just trying to figure out, like, how bad is long COVID? Is it going to get worse? Is it going to get better? Is it going to be the same? Is what their essential question is in this study. To understand how people's experiences with the virus have evolved in the context of growing immunity. Another lie, we are not having growing immunity, we're having waning immunity, as evidenced by the numerous other infections that are exploding right now in addition to COVID. So that's not growing, that is waning. Emerging variants, new treatments, and relaxation of public health measures. So this is just me being like, oh, these are all bad things because we have emerging variants, which is true. We have exponentially increased emerging variants. New treatments, we don't have new treatments. We only have one treatment. It's not even a treatment. It's a Band-Aid. And relaxation of public health measures, which is bad. All these results presented from the two surveys relate to the adult population age 18 or over. So that was true. So when I was like, they're a bit weird, doesn't have child data, it's because they're only looking at adults here. So we don't have any information from Canada on the children and prevalence of long COVID. Welcome to the new people popping in. Residing in private households in the 10 Canadian provinces. That's interesting. So they're looking at wealthier people, I'm guessing. I'll have to, what does Canada mean by private households? Let's double check that. Canada private household. Okay, so private households in Canada are just like where you live, just like normal homes. So in the study, long-term symptoms of a Canadian COVID-19 infection referred to the presence of symptoms 3 or more months after a confirmed suspected COVID-19 infection that could not be explained by anything else. Pretty standard, long COVID definition. This definition aligns with the WHO's post-COVID-19 condition case definition, with the exception that the latter requires a symptom duration of at least 2 months. To avoid confusion, this study used the terminology long-term symptoms after COVID-19 rather than post-COVID-19 condition. And I think that's important. I think there's 3 different things. You have your acute phase. I think there's post-COVID-19 or post-viral conditions or post-viral complications. And then I think there's long COVID. I think these are 3 distinct separate phases. And that having post-viral complications does not necessarily mean you have long COVID, and having long COVID may mean you have post-viral complications, but it also could just be related to systemic issues that have been affected or permanently damaged from the resulting infection. This is how I have been defining it. I think there's three distinct groupings. So after, yep. So as of June 2023, about 2 in 3 Canadians, 66%, reported at least one infection, with 1 in 5 having been infected multiple times. It is expected that the number of COVID reinfections will grow as the percentage of the population ever having COVID grows. And that's true. If you've been watching Canada, isn't there some kind of definition for long COVID that includes 30 plus days of symptoms? Not that I'm aware of. Everything that I've seen has considered long COVID 3 months or greater for symptoms. Yeah. I could be wrong. I haven't seen anything on that though. So if you've been watching the Canadian Severity Index, we can pull it up. I mean, I have it on a bookmark now that people have shared this with me. This one. So Canada, since last year, has been at high levels. It has not gone down. I could just remember. Yeah, it could be the 3. I do that a bunch, where I have a number translation. That's why I always double check. I wish we had that dashboard in the US or half the data. We have pretty good data. It's okay. I'm not a huge fan of how they're doing the severity weather reports. I think it's good if you're just like a public member and you're like, how bad is it? And you're like, it's bad. So sorry, that cartoon, when they're like, how's the weather? Oh, good, they fixed the 3 things in here, but these still haven't fixed. These have been broken for like a week in this live dashboard. But if we scroll back, so anything that is red is very, very severe high levels of COVID, and all the way back to July 2022, so around the time of this report that we're looking at for the 2022 report, since then, Canada has not gone down to low levels. Yep, there's the broken columns again. They have not gone down to low levels. It's been severe in all the different provinces for consistently for like a year. Crazy. So I just wanted to highlight that because Canada definitely has just gone up and up and up the reinfection numbers since that time. I'd be interested to see if they have that 2024 number soon. I mean, it wouldn't for another like 6 to 8 months, but I'll be excited for that. So, yep, it's expected to grow. Antibody levels decline over time. That's true. Novel variants with increased ability to evade immunity emerge. Yep, that's true. If you understand that, why'd you make those bad statements at the beginning? The percentage of Canadian adults who tested positive for COVID or suspected COVID infection since the start of the pandemic increased from 38.7% in the summer to 64.4%. Yep, you're just reiterating what you already told us in this one big bold thing. At this point, 44.6 Canadians percent of Canadians have experienced 1 infection, 14.4 2, 5.4% 3, and that's as of June 2023. So yeah, it's definitely gone up since then. But just puts it into context. I'll highlight that because that's important to have like a good lookup. And that's 3 or more infections at 5.4% of all Canadians. So while cases surged in the early months of 2022, infections have continued through to June 2023. In fact, in the 3 months prior, 8.9% of Canadian adults reported being infected. In the 6 months prior, the proportion was 13.7%. So they're trying to make the case that it went down. Not true. These numbers likely underestimate the true number of infections by June 2023, as individuals are not always aware they've been infected. So they're just talking about asymptomatic infections. Results from CACAS 2 showed that, so I'm just saying that because I think it's fun, CACAS, but it's just a boring one, CCAHS. So just as a FYI, if you tell someone CACA, they're going to laugh at you. but 41.2% of Canadians with antibodies from past infection never previously tested positive nor suspected infection. So we have to take that number with a grain of salt, because people can get sick and just pretend they're not sick. This happens a lot. So the 41.2% is going to be a higher end estimate. The number of asymptomatic infections is likely lower than that. The best studies I've seen have been estimating asymptomatic around 20%. So I think that a lot of people just like pretend they're not sick when they're sick, even if it's like when it's a mild sickness, they just tough it out. They go, I just got some allergies right now. So that's just, you gotta put these numbers into perspective sometimes. So infection and reinfection vary by age, as displayed in chart 1. So 0 infections is blue, 1 infection is gray, 2 infections is dark gray, and 3 or more infections is white. So it looks like the prevalence, the most likely to not be infected is 65 and over. The least likely is middle-aged people. Pretty consistent across the board for 1 infection. For 2 infections, it's more likely to be younger people. With 3 and more infections, again, it's younger people, between 18 to 50, or 49. Okay, so that's what we learned from the chart. Kind of interesting. I'll highlight the chart so I can talk about it sometime when I do the video. Hi, Souls Quest. Yeah, everything's well with me. Hope everything is going well with you. I've been getting bitter right now, but other than that, I'm doing pretty good. For older adults leading this group to take more precautions against a COVID infection. Oh, sorry. So as displayed in chart 1, older adults were less likely to report multiple infections. This could be attributed to the increased risk of severe disease from COVID for older adults, leading this group to take more precautions against COVID infection. Males more frequently reported not having a previous COVID infection than females, but both males and females are similarly likely to report multiple infections of COVID. Again, this is going to be playing into societal things where a lot of times, not just men and women, but men probably tend to do the tough it out, I just have allergies, pretend I'm not sick type of thing. So I think that plays into that. So again, I think this number is way over estimated. I think a lot of people pretend they're not sick when they are sick, and then don't take care of themselves accordingly. So reinfection reported also differed across racialized groups. Black Canadians more frequently reported having multiple infections than Canadians with Latin, Chinese, Filipino, Arab, and West Asian backgrounds, likely due to socioeconomic differences again. Oh, I just dropped my phone and realized you can see the article bigger by turning for it. Yes, you can. Yeah, if you do landscape mode, you can see the article bigger. And then you can also zoom, pinch and zoom. That's what people have told me anyways. For example, in 2020, Black and South Asian population were found to have a much higher mortality rate due to COVID than non-racialized and non-Indigenous groups. Again, socioeconomic disparities that are disproportionately impacting these types of communities. So it's systemic issues. It's not that one group is more susceptible. It's literally just the result of systemic issues. It's always important to say. So people have experienced symptoms differently since the emergence of Omicron compared to before. So I guess they're going to tell us the symptom changes. So throughout the pandemic, fatigue, fever, coughing, and sore throat have remained the most commonly reported acute symptoms. However, some symptoms have become more common since the emergence of Omicron in December 2021. Most notably, the percentage reported cough rose from 41 to 55, so that's interesting. So that shows that it's had an increased ability to impact our lung functions. And hit the chat icon in landscape and see the article full screen. Oh, interesting. So the cough rising means that it's causing more issues in the lungs. This could be just typical inflammatory response. It could be those microclots are building up in the lungs and trying to cough those out. Nasal congestion increased, so so we saw that microvilli paper where the microvilli actually like grow. COVID's able to reprogram those and make them grow, which can cause a feeling of congestion. This is my theory. We saw the piece of evidence. This is my theory of what it's resulting in. So I think that's just a sign that it's becoming more. It's having a greater binding affinity to our nasal passageways, the microvilli, and then the cilia. So the cilia and the it's binding to the cilia, and then it's causing the microvilli to grow, which they bud and then release more COVID particles and infect adjacent tissue. So I think that's just showing that it's becoming more, it's matched better to our bodies over time. And sore throat increase. So again, I think this is just showing that the transmissibility and the binding affinity to our receptors is increasing, but I haven't really looked at the throat stuff yet. So I can't really speak to that yet. In January 2022, prescription medications were approved for the treatment of COVID-19 infections. Pretty much Paxlovid. There's two others. I always forget the name. One's like Lagavir, and the other one is Veckerly or something like that. They're hard names to remember for me, but those are the general names. So then we have, in January 2022, prescription medications are approved among Canadian adults reporting a COVID infection. Since then, 3.1% reported taking such medication. Of these, 77% reported the medication was effective or very effective. Yes, it is. People should take it. It's an antiviral. It's good. If they can. There are contraindications. Use of prescription medicine increased with age and was more common among those with a pre-existing long-term health condition. So again, this is just playing into those societal factors where people think they're invincible. My body will fight off COVID. I don't need anything. I can tough it out. When no, you should use the resources available to you. So both are populations at higher risk of more severe disease or outcomes from a COVID-19 infection. This result aligns with Health Canada's authorization of the use of prescription antivirals for medications for patients at high risk of developing serious disease. I just saw someone wearing a nose guard under their mask. I thought that was interesting. A nose guard. What do you mean by a nose guard? Nose guard mask. Like this thing? Sorry, that's really small. I'll click on it. Like that? And I guess that's interesting, but I don't think it would do anything. I mean, if it was under the mask, I think that would be beneficial, but I can't imagine wearing a mask and then having this over the mask would provide much of an effect unless you're trying to increase the seal by having it like be a tighter fit. Like if this was like really tight and it was pushing against the mask, it would create a tighter upper seal. You might have to worry about like the bottom being like pushed out a little bit, which could open up. But in general, if you have a well-fitting mask and you don't, I wouldn't imagine you would need that. No, this looks like a sticker on the nose. Okay, we'll take another look. Sticker. Nose guard, sticker, mask. I'm just interested. Oh, it could be this, the anti-fog for glasses. Did it look something like this little yeah, no worries. I'm not sure if you can drop in a picture on the chat, but let's go back to the paper. So, so we already saw that. Oh, so the use of antiviral medication for patients at high risk. Yeah, we already read that. 1 in 9 Canadian adults have experienced long-term COVID symptoms. Most continue to experience symptoms. That doesn't make sense. You just reported above that the rate of incidence was like 16% in the 2022 survey. Yeah. I'll hear you out, authors. So 1 in 9. Is that 16%? My brain's not brain. I think that's 11%. Yeah, that's 11%. Okay. I don't know why they're saying that. This increased rate at which long-term symptoms occur in those with COVID-19 infections is a observed phenomenon that sets the illness apart from other respiratory illnesses such as the flu. This may be related to the fact that COVID-19 affects a wide range of body systems, not limited to the respiratory system, and has been documented to be able to cause organ damage in affected individuals. Yes, because it's a vascular disease that enters through the respiratory tract. As of June 2023, 19% of Canadian adults infected reported ever experiencing long-term symptoms. That's a weird sentence. Symptoms present 3 or more months after a COVID infection. This represents 11.7% of the total adult population. So that's how many people, almost 12% of the adult population as of June 2029. I don't know why they're changing the numbers. This doesn't make sense. So I guess some people are recovering. That would be the only explanation. So, Canadians living in the 10 provinces. The current burden measured in June 2023 is also substantial. 6.8% of all Canadians or adults, or 2.1 million people, continue to experience long-term symptoms. What? So 19% of Canadians have long-term symptoms that last 3 months. 11.7% of the total adult population is represented by this. And then 6.8% of all Canadians, or 2.1 million people, continue to experience long-term symptoms. Weird. This was in my dream last night. That was a weird moment for me. Okay, moving on. So on average, this group had their most recent COVID infection 11 months prior. That's interesting. Some Canadians were at greater risk of experiencing long-term symptoms following COVID infection. Adults with self-reported disability were more likely to report long-term symptoms than those without a reported disability. And I think that the reason that is because adults with disabilities typically understand what a true disability is, while people without disabilities don't typically know what would be considered a new disability or an actual disability. I think it's more of an awareness issue that's causing this discrepancy, more so than the people with disabilities being more. I mean, it could also be that as a factor, but I think the number is likely a little closer than than these numbers are here because of that mental discrepancy. When adults reporting one or more chronic conditions prior to the start of the pandemic were more likely to report long-term symptoms than adults not reporting chronic conditions. And I think so that's the other half of it. So that's the part I believe. I believe this number. The other number I don't necessarily believe. So other studies have demonstrated an association between pre-existing medical conditions and the development of long-term symptoms. Yo, oh. Does O slash mean something? I know S slash is seriously, or slash S is seriously. What's O slash? Oh, okay. I'm sorry. Just reporting on reality. 07. Okay. And adults reporting. I already read that. So, yep. Despite many different long-term symptoms having been reported, some occurred more often than others, with fatigue, brain fog, and shortness of breath. So impacting your brain and your lungs seem to be the most common occurrences of the long COVID. So these long-term symptoms have been reported in other international contexts. Differences are observed in the frequency of some long-term symptoms before and after the emergence of Omicron. Okay, so you can tell us. For example, since the emergence of Omicron, individuals with long-term symptoms are more likely to report feeling worse after physical or mental activity. So I guess since the Omicron variant, more people are having central nervous system issues, such as MACFS or loss of smell, showing that the virus evolved to cause more issues. Longer-term symptoms may take longer than 3 months to develop or return after an initial recovery. Among individuals who reported not experiencing symptoms 3 months or longer after a COVID infection in the summer of 2022, 11.1% have since reported developing long-term symptoms after that same infection that could not be explained by anything else. So I guess the people, that sentence is saying, from my understanding at this point, is that some people recovered, and then after some more time passed, their symptom either reemerged or they didn't actually recover, and it was just like a mental placebo. So the potential impact of reinfections on the risk of developing or exacerbating pre-existing long-term symptoms is important, considering the endemic nature of COVID-19. That is a false statement. It is a pandemic. Still a pandemic, not endemic. However, studies providing evidence of increased risk are limited in number and generalizability. As seen in Chart 2, Canadians reporting 2 known or suspected COVID-19 infections were 1.7 times more likely to report prolonged symptoms than those reporting only 1 known or suspected infection. And those with 3 or more infections, 2.6 times more likely. There we go. So what that is saying, that the initial prevalence after 1 infection was around 14% for Canadians. And then after 2 infections, that increased to 25%. And after 3 infections, that increased to 38%. So it's stacking. Essentially, the each time you get it, the rate is going up. The higher the probability you will get long COVID with each subsequent infection. So we'll highlight those because those are good call-outs. People that had their first infection early in the pandemic, though, were also more likely to report multiple COVID infections. For example, in the study, the average data of first infection for those with 3 or more infections was May 2021 compared to September 2021 for those with 2 infections, and May 2022 for those with 1 infection. Those infected earlier in the pandemic before vaccination and the emergence of Omicron were more likely to develop long-term symptoms, but also had more time since their first infection to become infected with COVID again. So it's that's nice. So that's basically acknowledging, like, hey, we don't really know why this is happening, because it could just be that The reason we're seeing this higher prevalence is because these people had gotten more infections over time because they got it early on, so you have more time for these stacking infections. Or it could be that the people that got infected later, that was after vaccination, so they had some level of immunity that was protective, that reduced the incidence of the long COVID itself. They're saying we don't really know what the reasoning is, but what we can say is that when we look at the relationship between infection number and prevalence of long COVID, that we're having this linear relationship. That's kind of what they're saying. However, as displayed in Table 1 below, a positive association is also observed throughout time when examining the above relationship by period of first COVID infection, suggesting that the period of first infection may not fully account for this correlation. So it's again saying that it's more likely the number of infections, not necessarily when you got infected. Oh, I've been wondering how they factor vaccination into long COVID risk calculations. Thank you. I need to let the dogs out. I will be right back. Yeah, so, well, they'll probably show us in this table. So I'll leave you to look at the table while I let my dogs out real quick. That's weird. The table's cut off a little bit. I don't like that. But I'll be right back. I'm back. Sorry it took me so long. I had to kill a fly. Got let in right when I was letting the dogs out. I don't like flies. Ugh. So, so now they're also looking at period of first infection versus the number of infections to see how it correlates with long COVID prevalence. And so they have people that got infected in the first year, 2020, the second year, 2021, the third year, 2022. And as we go down, the average went from 14 to 34 to 45. So people in the first year might have an even higher prevalence of getting long COVID, but it might not be significant because, like, if we look at the second year, we have 18, 18, 31, so approximately equivalent for first and second, and then goes to about the same, like a low end of the same, 31, 31. And then for if you got it in January of 2022, so that third year, we go 13, 25, 34. So it's likely just a little discrepancy fluke, or it could just be that it's more, you're more likely to just have even more than 3 infections. So that's probably what's happening, is that, like, you're having like 5 infections or 6 infections that are pulling this number up a little higher. But it also is sort of providing a little bit of evidence that if we get even more infections than these 3 infections, we're likely going to see an even higher stacking of long COVID prevalence. 2 weeks, months. I don't know your question. It's years. Yeah, no problem. So it's very likely that it doesn't matter when you got infected. It's just like if you got infected in that first year, you're more likely to have even more infections by the time you get to the present time. So it's kind of unnerving that, like, with each subsequent infection, it's sort of like a linear scale of like percentage chance that you get long COVID. I guess TikTok chat is faulty. Yeah, every once in a while people have issues with the chat where like something gets like blocked out, and I don't really have filters on my chats, so I don't really know. It's like TikTok shenanigans. So sorry about that. But yeah, so that's my interpretation of this table. But like if you like plotted a line, here I can do that. So if you do Shift Windows S, you can do the snipping tool. It's a shortcut. And then I just have to click on the image that popped up on a different screen, and it'll pop up right here. Come on, grab that corner. Do something, mouse. Whatever, I'll keep it small. So if we plot our best line, it's a linear increase between these three. So with each subsequent infection, it's going up like 15%. Because we started at around 15, then we go to about 30, then we go to about 45. He knows the secrets, not enough to know this. I mean, I don't think they're secrets. This is a published journal paper, but yeah, I can read and interpret it. Percentage who continue to experience long-term symptoms, symptom duration. So 42% of people might recover after a COVID infection, or that get long COVID. 58% of people do not. So again, I think it's more the number of infections that's the important thing. Oh yeah, the snip tool. So I actually had to learn that for work. They sent, not sent, but like the snipping tool was being discontinued, and like our work had like a specific version of the snipping tool, and it's like to re-access the snipping tool shortcut, use Shift, the Windows key, and S, and then that will give you the shortcut for the snipping tool. And then after I learned that, I use it all the freaking time now because it's really handy. But it's cool. So almost half of, if everyone gets COVID every year and we have to keep living with it, what's that mean for us as seniors? The unfortunate conclusion is likely disability, widespread, if it's unchecked. And we don't know, so like we know up to 3 infections. What's going to happen when we have 5, 6, 7, 8, 9, 10? Like it could hit a point where it stops going in a linear phase and it goes exponential. It could also go logarithmic. So we don't really know. We're this far into our knowledge base, and we have to wait a little bit. Yeah, and I know people that are at 6 infections too. And it sucks because like a bunch of people that I know, like I can like literally like see their cognitive slowing with each subsequent infection. Yeah, I'd like to live a lot more functional, healthy years as well cognitively. Which is why I try to stay so vigilant, because my brain is my most precious thing to me. I'd be fine if I lost body parts, but my brain, I want to keep that. Almost half of Canadians who reported that they continue to experience long-term symptoms also reported no improvements over time. So 50% of people that, like, we saw that number. So that's, they keep downplaying the numbers and screwing with them here. So right here, 58%, that's the number. 58% of people that get infected with that develop long COVID don't improve. Yeah, again, they say almost half, and then it's 58 right here. Okay, buddy. Whoever reported among Canadian adults who continue to experience long-term symptoms, about 80% have been experiencing symptoms. So 80, that's more alarming. So they should have had that in their figures. About 80% of people who get the long COVID, what can be defined as long COVID, experience symptoms for 6 or more months. And 42.2% a year or more. Depending on, of those who reported experiencing. Again, why are their numbers different? Oh, that's 2022. My bad. That one's on me. Depending on the nature, severity, and frequency of long-term COVID symptoms, the effects of such symptoms on an individual can range from mild to debilitating. Among Canadians who continue to experience symptoms, about 70% reported experiencing them every day or almost every day when symptoms were at their worst. That's not something you want to read. And 21.7% reported often being often or always limited in their daily activities. That is a wow finding. Overall, about 50% with ongoing symptoms reported no improvement in their symptoms over time. Again, it's 58.2. Among Canadians who reported ever experiencing long-term symptoms, females were less likely than males to report a resolution of their symptoms. Again, I think this is people pretending that they're not sick. I think men especially have a delusion complex over being ill, and they pretend they're not sick or they're not being impacted by things when they actually are. I do not believe this number. Sorry, that shouldn't be blue. It should be red. So I think a lot of women are more in tune with their bodies. So I think it's more like that. I know someone at 6. Yeah, I think I already read that one. Overheads, wow. Hoping to meet friends at break, but gotta think it through. Those 100-day cough folks, yeah. I mean, at the minimum, just wear a mask. Well fitted at 95. To report resolution of their symptoms and experience their symptoms longer on average. Again, I believe that's a delusional complex. So let's see. So men, women, pretty consistent. Over the 3, there's no statistic. If you ran stats on these 3, it wouldn't be statistically significant. Men, it's logarithmic. So I think that, yeah, probably half of men are delusional. But it is interesting. So like it would be showing statistical significance later on and earlier on. So men would be more likely than women in this scenario. Men would be less likely than women in the long term for long COVID. In the short term, but since this is a survey, we gotta like take these things into consideration, and I really do think men are delusional as a man myself. So I believe the number, the female incidence rate, I think that's accurate. I don't believe the male incidence rate. As of June 2023, more than 1 in 5 Canadians with long-term symptoms missed days of work or school. So that's 25%. So now we're looking at economic impacts. So that's as of June 2023. It's true, sometimes men are, but I can't tell you how many people I myself used to be like this, where like I was raised on stories of Shaq played his best game when he was really sick and he put up the best numbers that night. You can work through anything. You can push yourself. And then like I would have a habit for a long time where I was like, I'm not sick, blah 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 blah. Then I almost died of norovirus because I refused to get treatment. And then now ever since that, I make sure that I get treatment and get all the stuff. Like I was always good about vaccinations, but I wasn't always good about going to the hospital when I need to go to the hospital and to get treatment like that when I need to get treatment. And I got very lucky. I survived. But now I'm gluten intolerant because of the norovirus. And these are people with free access to healthcare. I don't know too much about Canada's healthcare system, but I believe you. I think they are what's it called? Unified public health system. I can't think of the word right now, but yeah, I think they do have that. Universal healthcare. Thank you. Brain's not brain. So results of the CACA FQ show that long-term symptoms interfere with many Canadians' livelihoods and education. That's the crazy thing. So I've seen lots of scientists that like they were showing how they were like prior to getting COVID, and now they can't even go through and read these types of articles because it's too much processing power, and their brain just like shuts down, or they can't like hold on to the ideas and the concepts as they're doing it, as they're like working through the paper. And that really scares me. And that's I've seen lots of different science creators on TikTok. Random question: would you outdoor dine in general, or right now, or no? Me personally, no. I mean, I'd rather outdoor dine than indoor dine. But like my partner has like lots of like work events, and I always turn them down. Like, no way, no way. I went to one and I was the only person masked, and I was like, hey, I'm sorry, I'm not doing this anymore. I'm not going to your work events. I don't trust your colleagues because many of them have gotten COVID multiple times at this point, and I've only known them for less than a year. Through my partner, I've only known them for less than a year. So yeah, no, I don't trust them. And no, I wouldn't at this point go out for outdoor dining. The only thing I would do would like people I know and trust, I would invite them over, I would cook for them, etc. That's what I would do. But I've been moving around a lot, so I don't actually have a lot of in real life friends right now. Ugh. I swallowed a really weird way, and it got like air. So, among Canadian adults ever experiencing long-term symptoms who are employed or attending school, 22.3% missed days. Okay, that was a dumb sentence. On average, they missed 24 days of school or work. You already said that at the beginning. This translates to 600,000 Canadians missing time from work or school, and a cumulative total of about 14.5. So that's good economic terms. So with an average of 24 days by 600,000, if you multiply those two numbers together, you get 14.5 million days of missed work or school due to long COVID. Thank you. Have a good one. Let's go. Yeah, year 5. Woo! Year 5 in a few days. I mean, we're already into year 5 because it started like around early mid-December. But we'll count it as the brand new year for year 5. So among employed Canadian adults reporting ever experiencing long-term symptoms, 5.3% applied for disability benefits or workers' compensation due to their symptoms, and 94% of those who applied received benefits or compensation. So very few people are applying, even though 22% have debilitating, 22% are often or always limited by daily activities, yet only 5% applied for benefits. So a lot of people are not applying for benefits even though they are fully disabled from the condition. But I guess it's nice that about 94% of those that applied received compensation or benefits. Among those working Canadians reporting long-term symptoms, the most common industries they worked in were healthcare, and so oof. The most common industries they worked in were healthcare and social assistance. Those are the professions. About 18% of those have long COVID. And then professional and scientific and technical services, about 17%, and education services, about 10%. I didn't read that part, but I'm also highlighting it. As of June 2023, about 100,000 Canadian adults have been unable to return to work or school because of their symptoms. And some estimates of the impact of long-term symptoms on work and school may differ from those previously reported because the study focuses on impacts experienced 3 or more months after a COVID infection. Only 1 in 8 Canadians who sought help for their... I haven't saved in a while. There we go. Only 1 in 8 Canadians who sought help for their long-term symptoms felt they received adequate care. So that's not good. That's saying that the healthcare system's not functioning properly. So while many Canadians have needed healthcare because of COVID-19 in the past few years, the pandemic complicated many Canadians' access to these services, factors including restricted entry into healthcare facilities due to public health protocols and the absence of medical personnel due to illness, slowed the delivery of healthcare services. While virtual care was expanded to service Canadians during the pandemic, these services are not always appropriate depending on clinical needs. As of June 2023, about 50% of Canadians with long-term symptoms consulted with a healthcare provider or service about their symptoms. Family and doctors and nurse practitioner continue to be the main point of contact for most Canadians for their healthcare needs, as about 83% of the above group reported consulting with either of those professionals about their long-term symptoms. Studies from other countries have found a similar percentage of people with post-COVID conditions consulted a general practitioner about their condition. So that's problematic because general practitioners are not going to be knowledgeable about COVID and long COVID. So that's going to be problematic because they're not going to know what to do. They're not going to know they're not going to be up to date on the most current stuff. They're good at a wide breadth of medicine. They're not good at new stuff. They're not good at focused niche depth. So that's why it likely is very problematic. The other most frequently reported healthcare services consulted for long-term symptoms were specialist medical doctors, pharmacists, and emergency departments. Of those who accessed a healthcare service for their long-term symptoms, the average number of different services consulted was 2. So whether due to a lack of resources, energy, or perseverance, people only tried twice to get some sort of help for their symptoms on average, which means that you're not necessarily getting the treatment you need because a lot of times you have to go to this doctor and they refer you to that doctor, and you go to that doctor and they refer you to another one, and you get bounced around until you find one that you can work with, which is unfortunately how the system is set up. So according to Kakao FQ, the current one, 40% of those who consulted a healthcare provider or a service about their long-term symptoms also reported at least one difficulty accessing those providers or services. Of the 800,000 Canadians with long-term symptoms who reported difficulty accessing a healthcare provider or service, 1 in 5 did not receive that service because of their reported difficulties. So about 25% of, not 25%, 1 in 5, 15%? 20%. I should know that. 20% did not receive the service because of their reported difficulties. So they had an issue so significant that they were not able to receive the service that they needed. And among those who reported difficulties, the most frequently reported problems accessing healthcare were waiting too long between booking an appointment and healthcare service, having an appointment canceled, rescheduled, or delayed due to the pandemic, and difficulty getting a referral. Being able to consult with these should be green. They're not mind-blowing. They're good to know. Those were mind-blowing. being able to consult with a healthcare professional does not necessarily ensure that an individual's need for treatment was fully met. In fact, 66% of those with long-term symptoms who needed healthcare services felt they did not receive adequate treatment, service, or support for any of their symptoms. Yike. That one's mind-blowing. Only 12.5% of Canadians, adults who need healthcare for the long-term symptoms, reported receiving treatment or services or support for all of their symptoms. And among those, yike. So, I guess I'll make this one green because that's even more mind-blowing. So, only 12% of people that, we'll say 13, only 13% of Canadian adults received what they would consider adequate care for their long COVID symptoms, and only 6% of that number received a proper long COVID diagnosis. That is crazy. Older adults, so this is just like a little info session box. So COVID-19 vaccine, older adults are more likely to keep up to date with their vaccinations against COVID. COVID-19 vaccines reduce the risk of severe disease, hospitalization, and death. Some research also suggests that vaccination may also lower the risk of developing long-term symptoms. Results from the KKFQ indicate that as of June 2023, 93% of Canadian adults had received one or more COVID vaccine doses. Less than 1% had received one. Looks like an I, but I'm guessing it's 1%. And then 13.8% 2, 29.4% 3, and 49.2% 4 or more. With respect to recency of last vaccine dose, 18.3% of the Canadian adult population were last vaccinated. That's one I want to highlight. 18.3% of the Canadian adult population were vaccinated in the last 6 months prior to the KKFQ, but this varied by age group and number of chronic conditions present prior to the start of the pandemic. Staying up to date with COVID vaccinations is particularly important for people at high risk of adverse outcomes, including people aged 65 and older, and people with pre-existing long-term health conditions. Adults 65 and older were more likely to have received a vaccination in the 6 months prior to June 2023 compared to 50 to 64 and 18 to 49-year-olds. Adults with 3 or more pre-existing conditions are more likely to have received a vaccination in the past 6 months prior to the survey collection compared to adults with 2 chronic conditions, 1 chronic condition, and no chronic conditions. So that's basically what they've been telling us earlier. Not surprising. People that are older or with previous health conditions are more aware of their health and want to make sure that they're doing everything possible to stay up to date on their health care needs. So moving on to the conclusion. So using data from the KKFQ and the KKA2, the study depicts how COVID-19 has evolved in the Canadian landscape more than 3 years into the pandemic. The results show that 1 in 5 Canadian adults have experienced COVID-19 more than once, and that many Canadians currently experience long-term symptoms for a COVID-19 infection. For the latter groups, these symptoms often have strong implications on many facets of their life, including their ability to perform daily activities, work, and go to school. So again, the authors of this study are just very focused on what is the workforce productivity loss from if we do nothing about this, and it's showing pretty severe. You should do something about it. So the study adds to a growing body of evidence around the association between COVID reinfection and the reporting of long-term symptoms, mainly that the more infections you have, the higher the likelihood you will get long COVID. Yeah, I'm glad you made it for the conclusion too. So among Canadians who reported ever experiencing long-term symptoms, those who continue to experience these symptoms, 58.2%, outnumber those who have reported them resolved. And again, people are likely not necessarily having them resolved. They could, I don't believe it though. As of June 2023, an estimated 2.1 million Canadian adults continued to experience long-term symptoms after a confirmed or suspected COVID-19 infection that could not be explained by anything else. Almost 80% of these adults, we already have that highlighted, we don't need to highlight that, Almost 80% of these adults had been experiencing long-term symptoms for 6 or more months, and about half reported no improvement in their symptoms over time. Is there anything new? Or are they just reiterating everything? With about 2 in 5 Canadian adults affected, healthcare. Okay, they didn't tell us anything new in their conclusion. So a lot of times people will try to ground it into context. Apparently these people are boring. So we'll just scroll up to the most important figure, just for the new person that popped in. So this is the most important finding, is that with 1 infection, the incidence of long COVID was about 15%. With 2 infections, the incidence of long COVID was about 25%. And with 3 or more infections, so they just bundled everything after 3 infections together, the incidence popped up to about 38%. So with each subsequent infection, we're having essentially a linear increase over time, or sorry, not over time, over number of infections or frequency of infection, where it's essentially popping up by about 15 to 10, so that's a 10%, and then 25 to 38, that's about a 12%. We'll say about 10% each time. So by the time you get to like 4 infections, we could project out and be like, oh, so that'll bump from 38 to like 50%. So unfortunately, it's stacking. It's not staying like 10% consistently over time. With each infection, you have the same rate. No, it's with each subsequent infection, your likelihood of getting long COVID goes up and up and up. Yes, data on 3+ infections. This is a Canadian study that was released December 3rd? December 8th, 2023, so not too long ago, that a lot of people have been like talking about. And they're like, what's the actual prevalence now? And the study shows that. They did a really good retrospective analysis of the Canadian population. We learned a lot, but like this is sort of the big take-home message. Yes, it's much worse. It's much worse. Where each subsequent infection seems to stack. So this isn't technically how cumulative probabilities work, but like you can think of it. So like you have like the 10%, and it's even worse than that. So I'm not gonna say it like that, but like all you gotta know: 1 infection, 15%; 2 infections, 25%; 3 infections, 38% likelihood of developing long COVID. Yeah, it's insane. By 4 infections, you could project out that it's going to be 50% likelihood of developing long COVID. And most people aren't resolving symptoms. About 60% of people that get long COVID don't resolve the symptoms, where it's likely a permanent impact. But I can't. That's speculation. I can't make that claim definitively. Because this study is only looking at number of infections, not necessarily like years since long COVID infections. Yeah, this is definitely a watershed event. Yeah. So I've heard this paper. I've heard some people talk about this paper. I really wanted to go through and read it, and yeah, it's a little more depressing than I thought it was going to be. But this is what I've been seeing. Like last year, it seemed like the prevalence as like it's somewhere between 20 and 33%, and that's pretty spot on the money, 25%. And that's probably was balancing with the number of infections. Oh yeah, here, let me show you the title. It's experiences of Canadians with long-term symptoms following COVID-19. They really should have put something in their title about reinfections or something like that. It's just a weird title. It doesn't make it sound like it's going to be screenshot. It doesn't make it sound like it's going to be on what it is. Maybe that's intentional, maybe that's not intentional. But typically when you write titles for papers, you like take like your most important finding and you kind of like stick it in there so that people can find it, and correlate one with the other. But yeah, this is the big takeaway, is that with each infection it's getting worse and worse and worse, which is not good. This is not good. Yeah, no problem. And thank the authors, the Canadian authors that ran this analysis and looked at it, because they're the ones that did the real work. I just read it. Sion Kwong, Stephen Earle, Janine Clark, Diane Zakaria, Elaine Demers, and Samina Aziz. I read a summary of this on our government website. Yeah, and they're definitely downplaying in here. Like, whenever you see me use red and purple, like, that's stuff that I really don't agree with, and I think purple is like an outright lie. So like, they have stuff where they're definitely downplaying in here, but like, you can't lie about the numbers. You can try to lie about the numbers and the data, but the data speaks for itself. So even if you do lie about the numbers and the data, people that know how to read the numbers and the data will be like, are you sure? Because I see this and I know what you're saying is a bunch of BS. But yeah, so this was a really good one. It's another nugget to tuck away, is that if you get an infection, make sure you don't get another infection. Are you sure? That's how I feel sometimes. I'm like, really? Are you sure? Like that HLA paper, the HLA gene, when they're like, oh, if you have this gene, you're protected from COVID and it's in white people. It's like, no, you just made up a bunch of stuff in that study, and I spent like a good 15 minutes tearing that apart in 2 different videos, maybe 25 minutes, I don't even remember. I just know that that paper made me very angry. It was a bunch of BS, and people are like, I've seen a couple studies now that like people wasted their time looking at this based off of that paper, and they're saying no correlation. There's a bunch of BS, and I'm like, told you. But yeah, I know I'm preaching to the choir, but how does this not scare most people? Because lots of reasons. Some people just like people are scared. They just think like the best way, what's that saying? The best way to go through is just to go through it, or whatever. They just keep their heads down and go through it. I forget the saying, but a lot of people just like whenever Scott Minor was talking about this the other day, and something I've thought about a lot. And like, when the people are being like, stop fear mongering, it's because they're actually afraid, and you're just making them feel fear. You're reminding them like, hey, this big scary thing is out there, and they don't like that, so they think you're fear mongering because you're inspiring fear in them, when really it's just them not being able to be mature and acknowledge their feelings of being like, oh my god, this big thing that is scary and out of my control to a certain degree is happening. So, but I think there's a lot of different variables at play there. They're either totally unaware of ableism or ableism. They don't think it can happen to them. Yeah, those things too. Definitely the ableism. A lot of people are very ableist because they haven't been exposed to the disabilities community, whether physical disabilities or cognitive disabilities. I don't think anyone is unaware at this point. It's been we're going into year 5, so I don't think it's possible for people to be unaware, even if they live out in the remote village somewhere. They don't think it can happen to them. That's definitely a thing too, is that they think they're impervious. And then they also like take their basic biology knowledge, where they're like, oh, if I get infected, then that means I have immunity, so I don't need to get vaccinated, and I don't need to, like, I will be more protected the next time I get it. And that's where the whole immunity debt concept came from, when it's like, no, you're taking something that sometimes happens with some viruses and applying it to COVID, and we know with COVID this doesn't happen. It actually damages your immune system with each thing, and that's like in this study, like showing how long COVID increases each time with each infection. That means it's doing long-term damage to your system. which is making it so that the next infection is even worse. Because our infections are becoming more mild, quote unquote, as they keep saying over and over. That's not true. But if something is becoming more and more mild and you're getting sick with it and it's causing it an even higher prevalence of this thing, then the only conclusion is that your body is worse off to this more mild variant, or your immune system. People think they're impervious to disability. Yes, they do. I've been in the disabilities community for a really long time because my father is paraplegic and my brother has mental disabilities. And like one of my favorite things that they told me is, or like, I don't know, they always give like speeches at the events and stuff, and they're really fun. And the one I was listening to a long time ago when I was like 12 or 13, so it's been a while, but they said like, you don't have disabilities yet. Because or that was one phrase in the speech, and then it's like I can't remember the exact words, but essentially it's just like we all have the ability to become disabled is the takeaway. Like we're all like, it's more unlikely for people to be healthy than it is for them to be disabled, because you can become disabled at any time in your life. Gonna go read the paper and post. Sounds good. No, you're all correct. It still just blows my mind. Yeah, blows my mind too. Unaware wasn't the best word, about more like wildly misinformed. Yeah, but that's sort of like the CDC is doing that. The governments around the world are all doing that. Even so much as like in this paper, how they're saying that, oh, because of vaccines and antivirals, because of the development of these things, the WHO declared an end to the public health emergency of international concern, when that's not what that means at all. The WHO ended the public health emergency of international concern because they failed to contain the epidemic in China, and I think Spain and France, and then the US, where it popped up. They failed to contain it in those locations, and then it became a pandemic, so they weren't able to contain it, so they had to end it, because the purpose of that is for epidemics, and now it's a pandemic, and they failed, and that's what that means. The answers don't take away from the stunned feeling. Yeah, for sure. Paxlovid question, I'm hearing conflicting reports when to start the course. The best thing to do as soon as possible. The general thing that they do is in the Paxlovid guidelines, it says you have to start it before day 5 of symptoms, which is hard now because sometimes you start symptoms and you're not testing positive until the 5th day, which makes you ineligible to receive Paxlovid according to the current guidelines, which sucks. So for the 5 days, it's hard to tell if it's better to start. I'm like 60-40, but like I can't like give medical advice and whatever, but like the general guidance right now is to take it as early as you possibly can to have the best effects on the 5-day course. Ultimately, the 5-day course is insufficient. It's not long enough. It needs to be a 10-day course. That's still in the works. I haven't seen any progress on that. I've been monitoring it every once in a while. But that's generally what the recommendation is right now. And I'm like slightly leaning towards taking it as early as possible versus like peak symptoms. After discussing with a dude. I appreciate you all here who understand and care about the greater community. I appreciate it too. First part is connecting to others is important. Is it better to start as soon as possible or wait until day 5? I feel like I've been told both. So the day 5 is the last eligible day to be prescribed Paxlovid. What they say right now is to take it ASAP. My son was sick Wednesday but tested positive today, and positive line was super faint. So any positive is a positive, so that's eligible to start receiving Paxlovid, provided they are over 12 and provided they are over I think 88 pounds. It'll say on the FDA guide sheet, so do that. But there's also, I haven't checked this one, it's like Verkely or something like that is another option that's for children, but I haven't seen like if it is a younger age availability than the 12 years. Welcome back. So I'm not sure. Oh, 23, so older child. Adult child. Yeah, so that should be fine in terms of the age. So, yeah, definitely a positive is a positive, so get Paxlovid. It's the best thing to do. If I get COVID, I'm getting Paxlovid ASAP. I'm taking it ASAP. I think we need studies to figure out when the perfect timing is for it. But ultimately, once we get that 10-day course approved, the 5-day studies won't really matter. No, you have to convince him to take. Well, it's gonna make him feel like it's gonna taste bad. Everyone that I have talked to has reported that, and like my partner when she was on it, that the metallic taste is really, really bad. But ultimately, like what an antiviral does is it reduces your. I'm sure you know, but I'm just gonna say it anyways. An antiviral reduces your viral load, and you have a lower viral load, you're gonna have lower symptoms. For that duration. If you don't take the Paxlovid, you are going to be feeling as bad as possible because you're going to have those peak viral loads for the duration of that thing until it goes down. When you take the Paxlovid, you're reducing that viral load, so you're going to have less symptoms, and it's going to make you feel better. Ultimately, even though it's going to taste bad, it's really annoying. It's like 5 pills a day or something like that, like 3 in the morning, 2 at night, or something like that. I don't remember exactly, but it tastes really bad. But it's gonna make you feel better, and then like you might feel worse after you stop it, but that's not because there's not a lot. It's not working or it didn't work. It's that it wasn't prescribed for long enough. The dose wasn't long enough, so you're going back to the levels you would have been at. I got it for him. Stubborn, but good luck in convincing him. It's great you have it. Any other takeaways from the paper? Yeah, there's a couple. One sec. Good job. So the other takeaways from the paper. So I'll just glance through all the things. Oh, that's a good one. Oh, 1 second. I have to let my dogs in. But I know exactly where I'm going to go next. It's going to be on the employment. I'm back. Okay, so the other good takeaway from this paper outside of the number of infections is these lots. So this is more for arguments. That for a person that has long COVID, they're averaging, for ones that can go to work, they're averaging 24 days of missed school or work. And the number of Canadians at June 2023 that was correlating to this was about 600,000 Canadians, which is the equivalent of 14.5 million missed days of work or school due to long-term symptoms, which has huge economic impacts. So that's one big thing. And then another is that 100,000 Canadians were unable to return to work or school because of their symptoms. And then the other big thing is down here in terms of the healthcare. So only 12 so I think this is the more important one. So only 12.5% of Canadians who needed healthcare for their long-term symptoms reported receiving treatment, services, or support for all of their symptoms. So about 13% of Canadians are reporting they're receiving adequate care for their conditions, but of these 13%, only about 6%, so less than half, are actually getting a diagnosis of long COVID. So that's wild. So that's another big takeaway is that our healthcare service system needs to be updated. And one of the big main reasons for this is because 83% of the people that have long COVID or what qualifies for long COVID are going to their, what is the word? Their family doctors and nurse practitioners are their main point of contact. So they're going to these nurse practitioners and family doctors About 83% of them are going to them with their symptoms, and these are people that have a wide berth of knowledge but not a depth of knowledge, especially for a brand new thing like COVID and long COVID. So they don't have the knowledge and the information to be able to diagnose these people with long COVID, to find them the resources they need, or to connect them with the specialists they need. So this is a point of care issue in terms of, like, it implies that we need to have an educational, like, mass educational thing of specifically family doctors and nurse practitioners, because these are the point of contact. This is the place where the long COVID people are going. So we have the place where they're going. So we need to train these people to know these are the symptoms of long COVID. This is what it, how you can diagnose if they hit all these points or whatever. And then we got to be careful about that too. That's a whole other conversation, because then that could disqualify people if you have like a checklist of people just going through the checklist. And like new things pop up where like you're not in the qualifying criterion of the checklist. That was a big issue with AIDS, the HIV crisis when it came out. So always we need to be very careful with how we're defining those things. But if they had something like that or had training, then you could take these people and then also connect with resources to the point of contact people, so they know, all right, this is the referral network that we can send it out to, that this is where we can go to like do your fatigue, so your ME/CFS or your POTS, or like these are the specialists you need to connect with so you can get appropriate treatment, appropriate care, because people are only going to, on average, I think it was two people, they're trying 2 different people and then they give up. And like the big number for that is like, okay, so those people gave up, and what does that look like? So people that 22% of people with long COVID essentially qualify for disability, but only 5% of people with long COVID, so 15% of people are not getting disability and compensation, even though they're completely disabled and can't work, therefore can't get money. No, that's not the right number. So only 5% of the people of the 20%, the 22%, get on benefits. So that's a big problem. We have to figure out how to make it easier for people with long COVID that are disabled to be able to get onto benefits, to be able to live and eat. So like those are the other big takeaways from this paper, is like we have a big problem in terms of people getting benefits because they're disabled. We have a big problem with point of care contacts and being able to get referrals and diagnose long COVID in the first place. And these are big systemic issues. So those are the other big takeaways. So like there's the science point, that's the big takeaway, which is the number of infections and that. But then there's also the systemic issues, which are the big takeaways. And yeah, docs are bad with new stuff, and that's why it will likely need some sort of training regimen to be implemented for all of the family doctors and nurse practitioners, because more and more family doctors are outsourcing to nurse practitioners. Like to be able to, like I moved to a new place, I'm in a different part of California now, and I couldn't meet with a psychiatrist for medications, continuity of medications for 3 months after I moved here. I still haven't been able to meet with them because they rescheduled it, so it was 4 months. And I still haven't seen, or I just saw the psychiatrist not too long ago. But in that meantime, I was seeing a nurse practitioner. So if like I had long COVID and I had moved and that, like that would be my point of contact because of how the system is set up right now. A lot of it is being outsourced and delegated to nurse practitioners because of the lack of resourcing and the lack of, like, we're in a physician shortage essentially. But yeah, that's that paper. I think I am going to log off. I just wanted to get through this one, but thank you all for swinging by. It was a fun conversation and I learned a lot from this paper, so I appreciate the co-working space. Bye.